The third issue regarding the biology of dose response is, do all participants respond equally to the same dose? No, not all participants respond equally to the same dose. The study titled Familial Aggregation of VO2 max Response to Exercise Training Results from the Heritage Family Study well illustrates this concept. The aim of this study was to test the hypothesis that individual differences in the response of VO2 max to a standardized training program characterized by familial aggregation. A total of 481 sedentary adult Caucasians from 98 two-generation families was exercise trained for 20 weeks and was tested for VO2 max on the cycle ergometer twice before and twice after the training program. The mean increase in VO2 max reached approximately 400 milliliters per minute, but there was considerable heterogeneity in responsiveness, with some individuals experiencing little or no gain, whereas others gained greater than 1.0 liters per minute. The results revealed that there was 2.5 times more variance between families than within families in the VO2 max response variance. The authors concluded that the trainability of VO2 max was highly familial and includes a significant genetic component. The figures demonstrate the individual differences in increase in VO2 max with training for 481 individuals of the study distributed across the 4 clinical centers: Indiana, Minnesota B, Quebec C, and Texas D. Next, we may ask this question: do all outcomes respond equally to the same dose? In fact, not all outcomes respond equally to the same dose. The study by Duncan and colleagues illustrates that not all outcomes respond equally to the same dose. This project studied whether the quantity and quality of walking necessary to decrease the risk of cardiovascular disease among women differed substantially from that required to improve cardiorespiratory fitness. A randomized, controlled, dose-response clinical trial with a follow-up of 24 weeks. 102 sedentary premenopausal women, 20 to 40 years of age, were randomized to one of 4 treatment groups. 59 completed the study: 16 aerobic workers 8.0 kilometers per hour group, 12 brisk workers 6.4 kilometers per hour group, 18 strollers 4.8 kilometers per hour group, and 13 sedentary controls. 81% were white, 17% black, and 2% Hispanic. Intervention groups walked 4.8 kilometers per day, 5 days per week at 8.0 kilometers per hour, 6.4 kilometers per hour, or 4.8 kilometers per hour on a tartan surfaced, 1.6 kilometers track for 24 weeks. Main outcome measures were fitness determined by maximal oxygen uptake and cardiovascular risk factors determined by resting blood pressure and serum lipid and lipoprotein levels. Results indicated that, as compared with controls, maximal oxygen uptake increased significantly and in a dose-response manner: aerobic workers greater than brisk workers greater than strollers. In contrast, high-density lipoprotein cholesterol concentrations were not dose-related and increased significantly and to the same extent among women who experienced considerable improvements in their physical fitness and those who had only minimal improvements in fitness. High-density lipoprotein cholesterol also increased among the 6.4 kilometers per hour group, but did not attain statistical significance. Dietary patterns revealed no significant differences among groups. Thus, the authors conclude that vigorous exercise is not necessary for women to obtain meaningful improvements in their lipoprotein profile. Walking at intensities that do not have a major impact on cardiorespiratory fitness may nonetheless produce equally favorable changes in the cardiovascular risk profile. Demonstrates the hypothetical dose-response relationships between activity amount and relative risk of selected clinical outcomes, and shows the variation in response. The next issue with regard to the biology of dose response is: does the timed course of a response vary for different outcomes? The answer is the timed course of a response will vary for different outcomes. In general, there are 2 types of responses: acute immediate responses and chronic training responses. In the project examining acute reductions in fasting triglyceride concentration the morning after an afternoon bout of aerobic exercise. Fasting serum triglyceride and cholesterol levels were measured in 7 subjects each morning after a 12-hour fast. 4 days of sedentary living were followed by 4 successive days of exercise and 3-7 days of sedentary recovery. The first exercise session lowered mean fasting serum triglyceride levels. The second session resulted in a reduction to during the recovery period. Fasting returned to baseline levels gradually, within 3-7 days. Rogers and colleagues investigated the improvements in glucose tolerance after 7 days of exercise. In detail, they investigated the effects of 1 week of intense exercise on glucose tolerance in 10 men with abnormal glucose tolerance. The 7 days of exercise did not result in significant changes in body weight or maximum oxygen uptake. Plasma glucose concentration at 120 minutes averaged 227 milligrams per day, and an oral glucose tolerance test logged before and 170 milligrams per day after the 7 days of exercise. There was a 36% reduction in the area under the glucose tolerance curve. Plasma insulin concentration at 120 min of the OGD averaged 172 micro/milliliters before and 106 micro/milliliters after 7 days of exercise. The area under the insulin curve was decreased by 32%. In contrast to the response to 7 days of exercise, 1 bout of exercise did not result in an improvement in glucose tolerance. These results provide evidence that regularly performed, vigorous exercise can be effective in decreasing insulin resistance and improving glucose tolerance within 7 days in some patients with mild NIDE. Associates conducted a study to reduce daily steps and assess metabolic changes. In their study, participants were recruited for 2 sub-studies by advertisement and received compensation. Inclusion criteria were asymptomatic non-smokers without family history of diabetes mellitus, medication use, or physical abnormalities. Exclusion criteria were walking fewer than 3,500 steps per day measured over 1 week. Max the G-Worker SW200 pedometer. Great Performance Limited, London, United Kingdom, are performing more than 2 hours of regular exercise per week. The studies were approved by the local scientific ethical committee, and participants provided written informed consent. Participants were instructed to reduce daily steps by taking elevators instead of stairs, and riding in cars instead of walking or bicycling. In sub-study 1, 8 men decreased their pedometer recorded daily steps from a mean value of 6,203 to 1,394 with outcome measurements made pre-intervention and at 7, 14, and 22 days into intervention. In sub-study 2, 10 men reduced daily steps from a mean value of 10,501 to 1,344 with measurements made pre-intervention and out 2 weeks. Dietary records were kept before and throughout the studies to ensure that habitual dietary intakes were maintained. Colleagues compared moderate and high exercise intensity with regard to variables associated with cardiovascular function and prognosis in patients with the metabolic syndrome. 32 metabolic syndrome patients age 52.3 years were randomized to equal volumes of either moderate continuous moderate exercise or aerobic interval training 3 times a week for 16 weeks or to a control group. VO2 max increased more after 8 than continuous moderate exercise 35% versus 16% and was associated with removal of more risk factors that constitute the metabolic syndrome number of factors. Aerobic interval training 5.9 before versus 4.0 after. P less than 0.01. Continuous moderate exercise 5.7 before versus 5.0 after. Group difference. Aerobic interval training was superior to continuous moderate exercise in enhancing endothelial function 9% versus 5%, insulin signaling in fat and skeletal muscle biogenesis, and excitation contraction coupling, and in reducing blood glucose and lipogenesis in adipose tissue. The two exercise programs were equally effective at lowering mean arterial blood pressure and reducing body weight -2.3 and -3.6 kilograms in aerobic interval training and continuous moderate exercise, respectively, in fat. The researchers concluded that exercise intensity was an important factor for improving aerobic capacity and reversing the risk factors of metabolic syndrome. These findings may have important implications for exercise training and rehabilitation programs in future studies. When testing dose-response relationship, there are several experimental study design issues that need to be aware of. First, there is a need to isolate single feature of dose, but the researchers can test multiple features in single study. Second, there is a need accurate tracking of dose performed and document any other changes in activity. Third, there is a need to provide adequate power to detect meaningful differences between doses. In addition, there are needs for measurements with high test-retest reliability, measurements sensitive to change high intervention fidelity, subjects who are likely to respond to intervention, an adequate number of participants.
Church and colleagues examined the effects of different doses of moderate intensity exercise in sedentary overweight or obese women with elevated blood pressure. In detail, they determined effects of 50%, 100%, and 150% of NIH consensus panel recommended dose of moderate intensity physical activity on fitness in women. Sample were 464 women ages 45 to 75 years, sedentary, body mass index ranged from 25 to 43. Randomized control trial with women assigned after baseline examinations to a no exercise control group or one of 3 exercise groups. Follow-up testing at 6 months. Aerobic fitness measure on max test using cycle ergometer. Or respiratory fitness are associated with high risk of mortality, and improvements in fitness are associated with reduced mortality risk. However, a poor understanding of the physical activity fitness dose-response relation remains. Randomized controlled trial of 464 sedentary, postmenopausal overweight or obese women whose body mass index ranged from 25.0 to 43.0 and whose systolic blood pressure ranged from 120.0 to 159.9 mm Hg. Enrollment took place between April 2001 and June 2005 in the Dallas, Texas area. Participants were randomly assigned to one of 4 groups. 102 to the non-exercise control group and 155 to the 4 kilocalories per kg, 104 to the 8 kilocalories per kg, and 103 to the 12 kilocalories per kg per week energy expenditure groups for the 6-month intervention period. Target training intensity was the heart rate associated with 50% of each woman's peak VO2. The primary outcome was aerobic fitness assessed on a cycle ergometer and quantified as peak absolute oxygen consumption, that is VO2 ABS, liter per minute. Results indicated that the mean baseline VO2 ABS values were 1.30 liter per minute. The mean minutes of exercising per week were 72.2 for the 4 kilocalories per kg, 135.8 for the 8 kcal/kg, and 191.7 for the 12 kilocalories per kg per week exercise groups. After adjustment for age, race/ethnicity, weight, and peak heart rate, the exercise groups increased their VO2 ABS compared with the control group by 4.2% in the 4 kilocalories per kg, 6.0% in the 8 kilocalories per kg, and 8.2% in the 12 kcal/kg per week groups. There was no treatment by subgroup interaction for age, body mass index, weight, baseline VO2 ABS, race/ethnicity, or baseline hormone therapy use. There were no significant changes in systolic or diastolic blood pressure values from baseline to 6 months in any of the exercise groups vs the control group.